Hello, my name is Janice Giroux, and I am the team lead for RPIW number 23. We are going to be talking on a TAC time of 20 minutes, and each member will identify themselves. This is our great team who has done amazing work this week, and I'm very proud of them. We had a great week. So looking at our workshop project form on RPIW number 23, we wanted to reduce the number of inpatient mental health readmissions from time of discharge decision to discharge. Looking at the current situation, what we were working toward was looking at the provincial target, which is to decrease the number of readmissions within 30 days to the mental health inpatient unit 50% by 2017. Also looking at the current situation, we know that as part of discharge planning, you must have appropriate community connections between the mental health inpatient unit and our community supports. You must have these in place to ensure a proper and excellent discharge. We also noticed that only 10% of the patients that were referred to transitional care team, referred to as TCT, on the unit. So 10% is really a very low number. So 78% of the patients left the unit without that contact. Staff roles also were not clear, and there was also a non-known date of discharge, so therefore they were called surprise discharges, and plans were not in place for the community. The TDD, the targeted discharge date, the data was not reliable on the SEM boards or on the chart or on the whiteboard. Looking at our target progress report and results sheet in the Department of the Inpatient Regina General Hospital Inpatient Unit, we saw that our walking distance, our baseline, was the RPN gathering belongings to take to the patient room was 196 steps. Our target was 98 steps. Our lead time in minutes was 54 minutes. Our target was 27. The quality of our number of defects per day, the percentage of discharge checklist not completed prior to discharge was 100%. Our target 0%. Our percentage of patients with TCT referral not contacted by TCT before the patient left the unit was 78% was our baseline, and our target is 0%. Also looking at our cycle time, our baseline was 54 and our target 27. Looking at our current state, so this is looking at discharges on the day of discharge, so again, referring to surprise discharges. Some of the starbursts you can see are the checklist to assist the team in the communication discharge plan, more effective rounds, D-1 is known and standard work, better standard patient information for community supports for the discharge. Looking at our lead time of 53.55 seconds, we had 90% of discharges the same day of decisions, and 78% of our referral to TCT was 0 time to contact the patient. So our current state looked at patient and family were told of the discharge on the day of discharge with no notice. Looking at our future state, looking at D-1, now we have SCM board will be updated, the multidisciplinary care plan will be updated, the lead time went from 53 minutes now to 19.55. The patient and family are informed of the discharge on D-1, so the family is present at discharge. The unit clerk now confirms the discharge and makes sure that all the appropriate referrals are in place. So what this is a smooth and transition, and actually with all those community supports in place. So looking at our TAC time of 60, this is based ideally on discharges done between 9 and 11 a.m. And the observation was 1 nurse discharged a maximum of 2 patients per day. Also looking at our PQA data, in reference to the provincial target, in June you can see that we had 12 readmissions. Also looking at the number of admissions and a discharge to ID, we know that there's discharges 4.5 a day and admissions 3.0 a day. Also PQA data, knowing that of the 11.6 that were readmitted to the mental health inpatient unit, actually 41% of the patients were readmitted within 7 days. And also within, the 8 to 28 days, 58.8%. Also looking at our PQA data, looking at the number of readmissions within 28 days, So looking at 1, readmission, 76.7, 2, readmissions, 15%, 3, readmissions, 5%, 4, we're 0, 5, readmissions, we're also 0, 6, readmissions, we're 2 out of 60, so 3.3% of our PQA data. Also looking at the number of readmissions with the data that we had available, there were 69 patients, and we noticed that out of that, only 5 patients actually followed up with their appointments. So we have a starburst of 42% patients have no documentation of a follow-up appointment being made. Also looking at their discharge decision confirmed, we noticed that from the day of discharge, we saw our PQA data of 90% of the same day of the discharge, and only 10% on D-1.
Hello, my name's Amy, and I'm a participant in this RPIW. This is our pre-time observation form. This form helped guide the team and really understand the process of discharging a patient truly through the eyes of the patient. It told us that patients were often left waiting while nurses and doctors scrambled to organize their discharge. The post-time observation form shows how preparation and adequate discharge planning greatly reduces patient waits and improves the overall discharge process. This is the pre-Kaizen standard work combination sheet, which visually depicts the wait that the patients experience once they are notified of their discharge. The post-Kaizen standard work combination sheet shows you how the team was able to reduce that wait time by making improvements to the discharge process. The pre and post Kaizen spaghetti maps show how Kaizen helped reduce steps for the nurse as they worked to discharge their patients. Better planning and timely notification will eliminate the scramble to locate patients' belongings. The percent load chart shows how the team was able to reduce the amount of time that nurses spent on tasks that were unrelated to discharging their patients. When nurses are caught up in non-value-added tasks, it ultimately results in patient waits. This chart also shows how there has been an increase in communication between the patient and their care team, focused work on patient care planning, and the consistent use of whiteboards in patients' rooms improves the flow of information for everybody.
Good afternoon. My name is Dev Francis, and I am going to talk to you today about improving multidisciplinary rounds. As a charge nurse on the unit, it's my responsibility to guide the rounds. We used to have, they called them bullet rounds, and they were Monday to Friday. We trialed them. We had ADS and pharmacy and intake on a telephone from the clinic, and then we had the rest of the team players in the room. It didn't work. There were some referrals that got missed. You couldn't hear some of the doctors on the phone. You couldn't understand what was going on at the meeting. So we trialed it again. We did a Monday, Wednesday, Friday. The inconsistency was still there. We used to have rounds Tuesdays and Thursday mornings. So we're going to go back to having rounds Tuesdays and Thursday mornings. We're going to invite all the key players that were on the phone back into the room. So we're going to bring the nurse back into the room, which is a key element of rounds. We're going to bring TCT, we're going to bring intake and ADS Tuesdays and Thursday mornings. So that was one of the big components of this RPIW for myself. We also did some streamlining of this multidisciplinary care plan. A lot of the information that was on this care plan was not being filled in correctly or at all. It was very busy. There wasn't enough room for a lot of the information to go on it. So what we did is we streamlined it to a different form, makes it much more user-friendly, and a lot of the stuff, the nurse can take this into rounds and she can have check boxes and follow along in rounds. So one of the things that I had to do, being the charge nurse, I had to approach all the doctors again and ask them if it would be okay to go back to rounds Tuesdays and Thursdays. So instead of telling them what day they had to go, I did the diplomatic approach and asked them. And out of the 8 doctors, I got 4 doctors on Tuesdays and 4 doctors on Thursdays. So they were a valuable input in this process. One of the other things we did is we had a script for rounds. So there is a purpose of the rounds. There is a time frame of the rounds. There's a person in charge of the rounds. They know when it is, and all the participants are involved in the rounds. And we're actually thinking about going to the flag system that we're having here for rounds, because just to keep the time on task. And as Val pointed out at the beginning, it is about the key players involved in the rounds. We did a collaborative approach to changing the rounds, and it is all about the patient. Thank you.
Good afternoon. My name is Dawn Jacobs. I'm a social worker at Mental Health, and I'll be presenting on Kaizen number 2, the improvement of planning for community supports. The idea summary sheet that we were tasked with was that it was found that patients were being discharged from psychiatry with no supports put in place, sometimes no appointments even. They had to design that on their own. So the measures taken was to create a standard work document completed so that when they are discharged home, they do have something put in place. So what we did is we went through the filing cabinet on 1D and realized that there was at least 4 of the referrals that were going to the same place, actually. So what we did was we gathered them up and developed what we kind of called Mr. Potato Head. We cut and pasted a bunch of the referrals that were there to take out the most important parts to make sure that they do go back to the mental health clinic, and the referrals are done in a swift motion. So as you can see, it's a Regina Mental Health external referral. The doctors were very pleased to see that. They said sometimes because there are so many and they're cumbersome, they were getting the wrong forms from the nurses to fill out. So what we did do is took it and designed it the way that 0D has theirs. It seems to flow, everything's all in order there. There was absolutely no negative feedback from it. So what we're doing is we're piloting on both sides right now. We have them, the other ones were removed and these ones are placed in, and we've had the unit secretaries start that, so it'll obviously go to where it needs to go there. One of the works that we need to design as well, based on this as an add-on, is the addictions component. We couldn't add it to what we designed because it will become too confusing. They're in different places, different buildings, different fax numbers and stuff. So that's work to be done to see if we can encompass the transitional outreach team, methadone clinic, and addictions, along with the concurrent disorders on one form if that's feasible. So that's work to be done as well.
Good afternoon. I'm Shara McFarlane, and registered psychiatric nurse on inpatient mental health. I'm presenting Kaizen number 3, which is improving patient info for discharge. This idea summary sheet shows the effects of a last-minute unorganized discharge where referrals to community supports were not received and the patient is not given adequate information, resulting in confusion. This is the current discharge care plan where important information for upcoming appointments lacks crucial information for the patient following discharge. At times, information is not filled in properly, leaving patient to make their own appointments and follow-ups. This is the post-Kaizen discharge care plan, and it includes clear documentation of the supports which staff can fill out throughout the admission. The process is simplified by using address stickers when supports are identified, and patient has all information, and it is also user-friendly for the staff.
I'm Leanne, and I'm going to talk to you about the Kaizen to improve the visuals for the targeted date of discharge. During this RPIW, we went on a field trip, and we came over here to the Pasqua, and we went around Unit 3D to view how they do their rounds. Out of that field trip came a couple of idea summary sheets. The first one had to do with how to use the whiteboard in the patient room, and we thought we could put the targeted date of discharge on the whiteboard, so that would help everyone, including the patient, be able to plan for their day of release. We discussed it with the staff, and we got a resounding no, don't do this. And our patients on our team were wonderful in this. They gave us their perspective, that from the patient's perspective, they were concerned that this might actually increase the anxiety for the patients, and therefore we're not recommending going forward with that. Also with the whiteboards, we found that the ones here, when they got cleaned, the labels were nice and stayed, and whereas the ones at 1D, the labels were made of paper, and when the whiteboards were cleaned, the ink got smeared. So work is underway with facilities management to improve those labels on the whiteboards. The second idea summary sheet had to do with updating and including additional information in the Sunrise Clinical Management System, and then expanding the use of that information on the boards. Again, we discussed this with the staff and reviewed the SCM board in the nursing room and its contents and use. It's a very busy board, and the next picture will show you that. And we determined through discussion with the staff that adding columns of information to this board would actually result in necessary information falling off. So there were no changes to the SCM board finalized at this time, and there may be some more follow-up needed in that regard. The one thing we did accomplish was to have standard work documented to help ensure that the SCM is updated in a timely manner with regards to any changes on the targeted date of discharge.
My name is Jamie Trainer, and I was a client participant in this RPIW. Kaizen number 5 was our 5S project. We 5S 2 shelving units in the kitchen area of the occupational therapy department. We began with 52 square feet of shelving space, 133 total items, and a pre-5S score of 1. These are photos of the top and bottom of one of the shelving units and another of the second set of shelving. Our first task was removing unnecessary items, which we did by separating items into garbage and donation piles, and by relocating items that were better suited in other locations. We then stored and rearranged the items on the shelves and ensured everything was labeled with accurate descriptors and quantities.
Hi everyone, my name is Tamara Campbell and I'm a client participant of the RPIW, and I'm here to report on the post-5S exercise. Of the 133 items on these 2 kitchen shelves, we reduced the number of unnecessary items to 67, and the square footage was reduced from 52 to 26 square feet. In the end, we obtained a score of 3. As you can see from these photos, there is more space after removing a large wood cabinet and separating items that were not necessary to perform tasks. All the items are arranged in a way easily accessible and visually spotted quickly. Shelves were labeled so that items could be returned to the proper place easily. In conclusion, the space is now safer from an occupational health and safety perspective. The energy in the room is positive and it flows, and less is more. Thank you.
My name's Carol Clausen. I was the sub-team lead for this RPIW, and you've heard the story of our week that started with our team observing and identifying waste on the Gemba. And the pre and post waste wheel just give you an idea of how much waste actually was addressed through the processes. I think more eloquently, what you'll see from our client's perspective, and that we had an artist who was great. So they drew a picture of the story that I think is the important one to look at, where you see before the hair is standing up on the patient, and you know there's panic and chaos, and they're really saying, you know, I'm panicking. What time can I go home? I have to phone for a ride. And afterwards, what you see is that calm, and you see a patient that's really happy, relaxed about going home, and knowing that everything is in place. The newspaper helped keep us focused, and we haven't left our process owners with too many items. They're the usual ones of dealing with forms, dealing with training. Those are the 2 major ones. Jen has talked about our targets, and I'm just going to highlight a couple of them. You saw the space improvement. Yesterday, there was only 1 discharge that we trialed all of the new improvements, and you start to see the impressive results. A 69% improvement in the lead time, 100% improvement in our defects, and that's through the use of that new multidisciplinary checklist, the setups, and the multidisciplinary rounds. So these changes really will enable a better patient experience. So in summary, our team focus and commitment to really have every patient leaving the inpatient unit with community supports in place and no waiting on day of discharge really made a difference. Thank you to everyone who helped us.